So to answer the question, we've decided in our unit that we're going to have specific individuals who will focus on a given area. So we have one or two surgeons that are going to be doing surface replacement with metal-on-metal surfaces, and they are the experts. They're following all the patients. They're following them longitudinally. We've decided that we have IRB studies and that we're going to have certain doctors do certain studies, and we're going to try to add good information to the literature there. So we're trying in a very systematic way to get data that would be deeper than the data that you would get from a registry, that would bring our patients into studies, and we can give good information back to the area, back to the field. I think a final comment would be, I think it'd be tough to be a patient today with the amount of information that's out there, and I think it's critically important that we as surgeons and physicians, that we spend the time necessary with the patients to educate them about these problems. And I'm sure all of the physicians here have great websites where they have lots of information for their patients, as well as our national websites, our national academy websites, and other organizations have websites. It's a confusing time for the patient, and it's our job to provide clarity for them.
Today I had a patient came in and was asking about the 30-year knee, which has been flooding the television lately, and I thought that was really sort of false advertising, in that they're saying that the knee was wear tested for 30 years. All right, but do total knees fail because of wear typically? No, it's not, and it's not even the mode of polyethylene failure in the knee. So they wear tested this knee, and that's only one possible variable as far as knee survivorship. And yet they're marketing it to patients as a 30-year knee. And they're using information that doesn't even really apply to survivorship of a knee, where it's just one component of it. We all know that polyethylene fails because of oxidation, because of subsurface delamination, because they're not put in good biomechanical alignment. So these are the problems associated with survivorship, not some mechanical testing of wear, which doesn't even apply clinically.
To get back to your earlier question, well, what are the things that, where are the opportunities? Well, the opportunities are where we tell the patients there are problems. So one would be infection. We tell our patients they could get an infection in total hip. The other one is in dislocation. And dislocation, obviously, acetabular orientation, femoral orientation, offset, leg length, all these things that we talked about. Those are the issues. The overriding issue used to be wear. I see it as less, but those are the things that you really want to discuss with your patient, and that's where the patient needs the bulk of their education, because those complications are the ones that test both the surgeon and also the patient. And I tell our residents, I say anybody can take care of a patient who does well after total hip arthroplasty. Where you differentiate yourself as a physician and as a clinician is how well you take care of a patient when they have a complication, and how you identify the nature of the complication, the treatment for the complication, inform the patient and the family. That's how, that's why the gentlemen around this table are considered master surgeons, because they are the ones dealing with these complications and providing the solutions for these difficult complications.
Two more broad questions, again, before we get into specifics. Two trends that I seem to observe is certainly over the last 5-10 years, we're seeing the hospital stay for patients for total joints shorten. And certainly I go back long enough, I can remember you were in for almost 2 weeks, and a week, then 5 days. The average seems to be 3 days now, but we're also starting to see at selective centers around the country outpatient surgery for uni knees, some total knees, and some total hips. And what do you see there? Is there any concerns on that trend, or is it better that we're actually trying to reduce hospital stay? Certainly it was probably done as a reimbursement initiative initially for some of the hospitals, but if you could all comment, Dr. Mackel, on that trend.
Well, I've watched the trend too go down from 21 days and didn't move the lymph to now the 3 days and sometimes the 2.5 days that you try to keep a patient in. But I think there's a role. I think there's a role for both, and what I mean by both is there's some patients who are going to be in 3 to 5 days, 3 days, 4 days, and they're going to go to an extended care facility. And so they're just going to be in another environment for another 2 weeks, 3 weeks, just getting their rehab in. I think really what it boils down is to what resources the patient brings to this endeavor. That usually means their own health, their own physical health, their own motivation, and they're also, and I think it involves what their home environment is. What family do they have available to help them after surgery? It boils down to their other medical problems that they have. And I think there's a role for both. I think our 40-year-old patients, I think their ability to get home and rehab quickly is definitely how we should go. For our much older patients, our 70 and 80-year-old patients, I think many of them are handicapped, and though all of us kind of practice on the East Coast of the U.S., it's much more difficult for our patients who live on the East Coast in two-story homes to go home and rehab. Whereas our West Coast surgeons, if their home is on a flat bed and everything's on one level, it's much easier for those patients to get home. And I think that's how those of us on the East Coast are somewhat handicapped for our patients that live in two-story homes, three-story Eastern homes.
Lou, your impressions on that trend?
I would sort of echo what Audrey says. And again, you have to, every patient's different. Every patient's an individual, and you got to be mindful of, again, what sort of support do they have at home. Sometimes they're elderly, they have an infirm spouse, and we try to, part of our, before the patient even comes into the hospital, we try to head off some of these problems. We have a patient comes in for what I call prehab. So they come in and meet with a physical therapist. They can tell them what to expect as far as their exercise they're going to be doing while in the hospital, introduce them to some of the gear that's going to be involved with their care at the hospital. And they meet with the nurse to discuss their medical issues that may require special care, and the family issues as well. So what is the home environment? How many steps do you have to get inside the house? And the best job that we can do prior to surgery, the patient's going to come into surgery pretty much having a familiarity. They know what to expect. There's some really interesting things on the web patient interaction. I don't know if any of you guys have used edheads.com, which is sort of neat. The patient actually is treated as if they were the intern or the first-year resident, and they take you through the preoperative exam and the prep and everything, and patients enjoy it because it is very interactive. So I think we need to be clever. I think that doing a little bit more on the front end might serve to safely decrease some of the hospital stay, but I have no interest in sending someone home just to improve a number by a half a day, only them to sustain a significant complication at home. I don't want them having their pulmonary embolus at home, or I don't want them having their myocardial infarction or anything like that at home. I want control of that patient until I know they're medically safe.
Dr. Rubash, any?
Well, no, I would just summarize. I think you heard a wonderful explanation. It's management of the patient's rehabilitation. It's management of the perioperative complications appropriately, and it's patient education. So there are those patients that can go home, and if they want to go home, we let them go home in 2 days or 3 days. And there are those patients that are going to be in for a while for a variety of reasons, and you keep them there. The key is to have an algorithm that's part of your office and hospital service line that says, you know, these are the critical points along the perioperative period, along the pathway, and so the patient knows what you're looking for at each given day and at each given visit. And they know how to get in contact with the physician and the physician's team. They know how to get in contact with the hospital, and most importantly, they're educated. This is the plan. These are your expectations. If you vary from these expectations, we need to know about it. So and I agree. There's no reason to do it just to do it. You do it. You let them go home for the right individual, and that's the only person that safely should go home.
Sponsored by the Spine and Orthopedic Institute at St. Vincent Charity Medical Center. Quality you can believe in. And co-sponsored by the Joint Implant Surgery and Research Foundation, dedicated to the advancement of total hip, knee, and shoulder surgery since 1971.